And now I have the distinct pleasure of inviting both Chiara and Andrea to join us and
Hello.
talk a little bit
Hi,
about autoregulation assessment.
Hello.
Hello.
Hi, Arti. Hello to everybody. And it's our pleasure to be here with you. And now I leave the floor to Andrea, the rising star on transcranial Doppler that we have here in Genova.
Thank you, Chiara. Shall I share the screen?
Yes. I think
Okay.
Erika can stop sharing hers.
Okay. Okay. Can you see the presentation?
Yep.
Yes. Okay, perfect. So first of all, these are our disclosures. We don't have conflicts of interest. And I will start from the very beginning. So from what we all know very well about cerebral autoregulation, which is the ability of the cerebrovascular system to keep blood flow constant between a certain range of mean arterial pressure. Usually this has been described between 50 and 150 millimeters of mercury of mean arterial blood pressure. We'll see that this is not so fixed. Another thing that comes at first glance clear is that we can also have the same thing for oxygen concentration in the arterial blood, but considering CO2 concentration in the arterial blood, this is not true. So we don't have an ability, the cerebrovascular system does not have the ability of how to regulate the blood flow according to PaCO2. And this is because we know that increasing pressure of PaCO2 in the arterial blood may lead to vasodilation, whilst reducing PaCO2 may lead to vasoconstriction. And this is very important, and we'll see why. So this is the scheme we all started studying with, but the physiology is a little different because this range of autoregulation in a healthy patients, it's preserved, but it can change with physiological changes. For example, in the elders, this range is slightly shifted. And then there are other conditions that, of course, can impair autoregulation, which is trauma, cerebral ischemia, and subarachnoid hemorrhage or intracranial hemorrhage. What's happened when we have a damage in a more wide terms is that this range of autoregulation changes from hour to hour. So we will have a narrow range of autoregulation. This may be shifted from 50 to 150 millimeters of mercury of mean arterial blood pressure or cerebral perfusion pressure. And this is just to remind that basically in every kind of disease or hemorrhages, we have a decreased cerebral autoregulation. So what's happening when we lost autoregulation? Basically, we lose a system that prevents the brain from damage, both when we have hypotension and hypertension. And the idea that there is a range of autoregulation is something that it's very clear. This is the fourth edition of the Brain Trauma Foundation. We see here at level 2B a recommendation to keep our cerebral perfusion pressure between a range which was historically set between 60 and 70 millimeters of mercury. But it was already clear that this range cannot be fixed for every patient at every time, because the optimal CPP may depend upon patients' autoregulatory status, which is something that changes in the acute setting hourly. So how can we assess this range of autoregulation in our patient? what we can use is the measurement or a surrogate of cerebral blood flow. Usually, blood arterial pressure is very easy to measure, and also cerebral perfusion pressure. So the very tricky part is to measure the CBF. How can we do that? There are a lot of different techniques to measure CBF. In an ideal world, we all wanted to see and we would like to have PET, SPECT, CT perfusion every time and on our patients. This is not suitable, we'll see why, but there are a lot of different indirect and invasive and non-invasive methods to estimate cerebral blood flow. For example, transcranial Doppler is a tool that comes to help in this term. As we were saying, the gold standard is still PET or CT perfusion. It has a good spatial resolution, but of course there are lots of limitations. We cannot take our patients every time to a CT perfusion when we have to check the autoregulatory status of the patients. It's very expensive. So the non-invasive methods can come to help us. For example, transcranial Doppler. Which are the advantages of this technique? First of all, it's fast and easy. If you have a training on insonating the mean cerebral artery, which is the most easy one to insonate and the one that can tell us the most about the autoregulatory status of our patients, it's very, very easy. It can take up to a minute if you're skilled. You can use it in a continuous way in order to monitor the autoregulatory status continuously. It's safe for the patients and the costs are very low. There are, of course, some limitations. As we were talking about PaCO2 at the beginning, the main problem is that it is important when we do our evaluation about autoregulatory status of the patient to keep PaCO2 constant at a fixed value. We can then value that, we can change that value according to the normal practice, but when we are gonna test autoregulation, it's important to keep PaCO2 stable. So what are we going to do with our TCD? We're gonna measure the CBF. And how is this possible? Because of a correlation between cerebral blood flow and flow velocity of the insonating artery. This is true if, again, we keep the cross-sectional area of the artery constant. So if we keep the PaCO2 constant. What can we do with our TCD once we have insonated the artery required? We can test a static autoregulation through a map challenge, as we'll see. We can test a dynamic autoregulation with different methods. One of these is the carotid compression. And then we can monitor continuously the autoregulatory status of our patient through an index, which is called the Emax index. First of all, static autoregulation. How is it tested? The most common test is called the map challenge, which consists in giving to our patients a bolus of usually norepinephrine in order to raise the arterial blood pressure and so raise the cerebral pressure perfusion, and then assess the flow velocity, usually the mean flow velocity, during the time. Ideally, when the autoregulation is preserved, what we will see is a raise in the mean arterial blood pressure, but a mean flow velocity that it's kept constant. Why? Because the cerebrovascular systems compensate this increase in arterial blood pressure with vasoconstriction. So an increase in the cerebral vascular resistance. Measuring the percentage variation of the cerebral vascular resistance and the cerebral perfusion pressure, we can then see if the autoregulation is impaired or preserved. Of course, before testing with a bolus of norepinephrine, we have to be sure that this is going to be safe for the patient. The dynamic test of autoregulation is slightly different. It can be performed with carotid compression or during a Malsalva maneuver made by the patient. So this may not be suitable every time. What's this test? We can monitor over time different values, arterial blood pressure and CPP, and then the flow velocity of the artery we are insonating. As we can see, we may register a baseline flow velocity before the test starts. When we make this compression on the carotid homolaterally of at the side of the artery we are insonating, we will register a reduction in the blood flow, and so a reduction in the flow velocity. These may be kept for some seconds, and afterwards, if the autoregulation is preserved, we will see a momentaneous increase of the flow velocity after the test. Measuring these two different flow velocity, we can then have a ratio which can tell us if the autoregulation of our patient is preserved or impaired. And in literature, it has been decided to use 1.1 as a threshold of this THRR test. So, putting everything together and heading through our conclusions, monitoring all these different values from our patient, we can have a constant idea of what autoregulatory status of our patient is. And putting especially together the mean flow velocity and the variation in arterial blood pressure, it has been described an index which is called MX index, which is it's basically a correlation between these two parameters that may be a linear correlation with a value above 0 or a linear correlation with a value less than 0. What we would like to see, as we have said, is that changing in arterial blood pressure does not reflect in a change in flow velocity. Whilst in patients with impaired autoregulation, every small change in arterial blood pressure can cause changes in flow velocity and so in cerebral blood flow. This is the graphical explanation of what we have said. There are some limits, of course, of autoregulation, which are lower and upper. Historically, these were set between 50 and 150 millimeter of mercuries of arterial blood pressure, as we have said, but in measuring continuously these values, we can actually highlight a curve which is personal for every patient at that moment of time. And this may change from hour to hour in the first phases, so in the acute phase. What is telling us optimal MX? It's telling us that there are some values of cerebral perfusion pressure which we have to aim as a target for our patients, and may not be, as the guidelines were saying, just between 60 and 70. For example, in this case, we can clearly see a curve which plots MX index and cerebral perfusion pressure, which basically tell us what's happening at different values of CPP to the autoregulatory status of our patients. If we keep a CPP below 70, then the autoregulatory status of our patient is impaired. The same is happening if we keep a CPP above 100, more or less. So our ideal target in this patient in this moment is to keep a CPP preferably around 80 millimeter of mercury in order to be sure that the cerebral vascular system is able to autoregulate the cerebral blood flow. There are different softwares and tools that can help us to identify and monitor cerebral autoregulation. Here we are using the ICM Plus software from the Cambridge group. And this is an example of how this monitoring can help us to personalize the care of our patient based on its status of cerebral autoregulation at that time. Thank you very much for your time.